Well, good morning, everybody. Welcome to the webinar this morning. I'm personally really excited to be sharing what has been a culmination of around 6 months of work across multiple different health systems. The reality is we're tackling a hugely important topic at a really critical time in care, but it's probably best to start with some introductions before we take you through today's topic. My name is Oliver Brown. I'm one of the vice presidents here at Zivver. My focus is really around driving our strategic go-to-market into the healthcare system, specifically the NHS here in the UK. But to give you a little bit of a background on who we are as an organization, Zivver is a Dutch business founded in the Netherlands in 2015. Over the last 8 years, we've seen exponential growth, and now we support over 70% market share within the Netherlands and equally driving that into the UK. We have offices based in London, Amsterdam, and Berlin, and we've been commissioned across the public sector in 4 separate EU countries. And this really is a testament to the value that's derived from clinicians across the globe. I think we also want to touch upon pedigree that sits outside of healthcare, right? We work with a number of key local authorities, municipalities, again within the public sector, and again across 4 separate EU countries, with a plan to launch into the US in the near future. Before we go into the topic and agenda items in a little bit more detail, I'd also like to introduce you to Liam, who will be sharing much of the work that we've been doing across the last 6 months, and also some of the key trends and themes that we're seeing across the healthcare system, both in the UK, but equally internationally.
Good morning, everybody, and it's lovely to be here this morning. I am Liam. I work with a range of organisations inside the NHS. I have done a lot of work with experimentation around digital across a number of frontline providers. I have advised the Health Foundation, who have just released a very exciting grassroots programme around driving new care paradigms and concepts using technology. And I've also advised NHS England and NHSX over the recent years. I am working with Zivver this year I will be telling you exactly what it's about presently, but to try and look at how we can translate some of the fantastic and really interesting work that's going on in a parallel health system, particularly in the Netherlands, and how and where this can be translated into application in the NHS, as we'll be talking through shortly.
Fantastic. Thank you, Liam, for the incredibly warm introduction. Just a couple of housekeeping items before we jump into the session today. One, we are going to leave all questions and queries at the end. Really looking forward to this session. Think it's going to be incredibly positive and looking forward to interacting with you all at the back end. But to just jump into the 3 agenda points. Number 1, we're going to be exploring the most pressing problems with communication that we know is not just in the NHS, but also health and social care systems that are simply trying to integrate against a really, really difficult landscape. Number 2, we're then going to go through some case studies and stories from other health systems and care providers with a particular view on learning from the Netherlands that directly relates to the problem statements that we're seeing across the NHS. And then the last agenda item is that we will be looking at how this can essentially translate into not just different parts of the healthcare system in the NHS, but also in the systems that are looking to work together across different kinds of providers, fundamentally focusing on the integrated care system strategy here in the UK. At this stage, I'd love to hand back over to Liam, who's going to take you through the rest of the session.
Cool. So just to say, in terms of the next couple of sections I'm going to be taking you through, I'm expecting this will probably run to around about 40 minutes. I'm going to start by talking a bit about the problem of communications that we're seeing in the National Health Service. Because there's a lot of different ways that we describe health, but actually functionally, if we break down what health is, quite often a significant, if not sort of majority of the work that we do is about communication, whether that is understanding what's going on with somebody and receiving information about them, providing a diagnosis, helping to coach and support them through their journey, and continuing to have that conversation in a number of different ways, which of course is getting more and more complex as people and their care and multimorbidities get complex too. And so to look at this, I suppose, from a system or national level, I've tried to outline, I suppose, some of the biggest areas where we are really seeing challenges in the NHS that relate to communications and probably the backdrop of some of the things that we're going to be covering in this session. I'd be surprised if you're not familiar with any of these. I think this is probably a bit of a description of what many organizations are living and have been living for the last couple of years. So firstly, of course, we have huge demand. The demand is growing up, the population is aging, they're getting more conditions, the prevalence of lifestyle diseases continues to go up, as does the demand on the system and the requirements for care. And of course, the more conditions people have, the more complexity of demand that we see. However, in the other hand, all we need to do is look at BBC News over the last 6 months and see the real challenges we're having in workforce. The words safe staffing levels continually comes up in the other parts of the work that I do. And realistically, we're in an environment where, particularly during peak seasons, the level of staff pressure is incredibly high. However, because of the waiting lists and other challenges that we have throughout the year, it continues to be something that runs throughout the NHS calendar year. Second, we have one of the biggest ambitions that we've ever seen in the National Health Service in terms of trying to integrate systems to bring together the silos and functionality and trying to get system partners to work together. Now, of course, efforts have happened in the past, but actually what we're talking about now is trying to bring the community in place together and lots of different organizations who probably wouldn't have played a part in that, in that, so particularly around community assets and schools and other parts of local authorities. We saw a big digital revolution during COVID, and we told ourselves and others a lot of stories. But actually, if we look at the sort of the tailwind that's followed COVID, what we've really seen is that when you go down to individual services, that accessibility has been one of the reasons that it's continued to hamper it. Often, if you speak to the average service, they'll say, well, our patients are complex. The people who we engage with the most tend to have very specific different challenges around their accessibility, not just in terms of digital knowledge, but now there's financial going on quite a lot. There's all different kinds of accessibility challenges, which means that often when digital technologies are presented or proposed, they're only starting to serve a small portion, which of course means that providing digital care, the benefits case can look a little bit patchy. Next up, communication shifts have been really hard. I personally have been involved in doing big experiments around communication using chat within some frontline providers. And whilst there's always benefits there of trying to be able to do them, given the pressures that we've got at the moment, behavioral change, trying to think about different ways of working with communication tools is incredibly stressful. Like I can remember meetings where sitting down with teams who are about to shift across to a different way of working, have been crying because of the perceived challenge it's going to have and how, given what the work they're doing is really, it adds extra pressure. And I think what we're also seeing at the moment throughout the year is that as we start to get to winter months and other areas where seasonal pressures are continuing to build, central teams, the organizations themselves are having to try and take the pressure off, and transformation is now having windows where it really can't happen because of these pressures. We've been told that the NHS app is coming. We've seen some of the plans, and post-COVID, we had pretty much every organization talking about patient portals and the promise of them. But of course, this promise has kind of gone on pause whilst we wait for the national roadmap to play out. The NHS app is supposedly going to be the all system for how communication should happen with patients, which we'll be covering in terms of some of the lessons from the Netherlands. And many organizations are now waiting and saying, well, what communication transformation should we be doing whilst we wait for this thing to come? Because what we don't want to do is to do it and then have to do it again in 2 years and shift something over when we could have been delivering transformation elsewhere. Finally, digital is creating all different kinds of tools. It's creating all different kinds of things. And organizations are now finding that the pathways are getting more complex. And whilst digital offers the future promise of simplicity and things being easier, that's not necessarily the experience that we're having within frontline services. And all of this is incredibly important because all of this is incredibly important. And I think what I've done is I've tried to take around 5 communication problems, explicit functional problems that the NHS is going to have to tackle in order to be able to get through these. And I'm not going to talk through them here because I've got a number of quotes from discussions that we've had from people inside the NHS. So the first part of this research has been very much talking across a number of people in different frontline operational clinical roles and also within systems to say, well, actually, what's the biggest things that are stopping you being able to improve your communications? So I won't read them now, but these are all things that we're going to have to try and think about and tackle in the National Health Service. And I was really pleased that when we sent the invite out for this, we got some emails back from people saying this is exactly some of the problems that we're looking at this moment in time. Problem 1, And I'm not going to speak too much around this during the session itself, because I think this is kind of where, in terms of application, this kind of fits exactly Zivver's primary use case. But what we're finding at the moment in the NHS is that more digital tools, more digital sprawl is happening, and many organizations still don't have any tools to actually stop problems happening when they occur. Of course, when we think about cybersecurity and data breaches, we think about making sure systems are resilient and they can't be hacked. But actually, if we look at most of the media stories that have been in the press over the last however many years, reply alls to people, sending it to the wrong person, different kinds of things, this is human error. And this is one where, effectively, if you speak to the folks in DPO teams and say, what tools do you have to stop someone sending that email when it happens? They don't. Like, what they're limited to is education sessions, putting posters up in toilets. And actually, as we know, in an NHS where everybody is under more pressure, more human error counts. There's a fantastic survey that talked about, clinical outcomes at different times when someone sees a GP. And if you see a GP on a Friday afternoon, the same, you'll be less likely to get good care. But the same problems effectively happen in terms of human error. What we're seeing is an increase in human error that's parallel to the pressures that are happening in this health service. And yet there aren't any more tools to be able to support this. Secondly, accessibility is so important. Many of our individuals who are using services as patients, or including social care as citizens, or people receiving other forms of care, is that inaccessibility and exclusion is meaning that we can't really get the benefits or the perceived benefits of digital happening. We keep bringing these new digital channels, but we had to stop them because they don't meet the needs of the user. It's created more barriers and more things that they have to go through that they don't know how to, and then we end up being an IT help desk for them. Our pathways are getting complex because actually digital tools can't serve all of our patients. There are very few areas where you can actually genuinely serve all of the patients with. And that tends to be actually parents of child services or early condition areas. For the rest of them, it's very difficult to be able to serve all of the patients. And so pathways become much more multifaceted. And of course, again, barriers. Patients can't or won't use this app because it creates too many of them. And actually, we'll be delving into that when we talk about the work in the Netherlands. Number 3, when we talk about all of the digital stuff that's going on at the moment, we talk about the different things where we want to improve those moments in care. Well, a lot of the digital technology that we have doesn't actually be able to help us to be able to transform or change that instance where we're engaging with somebody and communicating with them. So, for example, in a child speech and language therapy service, I won't go through all of this on the list, in terms of an ENT service looking at patients and their tonsils, where they effectively have to come in because there's no way they can securely receive a photo. There's a lot of work that is going on in the National Health Service right now that is happening and not changing because there's no tools to securely allow that to change. And so people have to keep going on and keep bringing that person in to see something, to triage them, or are unable to stratify risk and be able to see them. Like, speaking to health visiting teams at the moment, they've seen the value of it, but now they're being told they can't use WhatsApp when they started using that when COVID came along. Integrating systems. We're supposed to be talking about working with lots of different other partners, but the landscape, not just in terms of culture, in terms of priorities, in terms of politics, but in terms of the technology they're using. How do we collaborate with the local authority when they're working on Google? How do we work with social services and safeguarding teams when they're working on IT systems? Voluntary and community assets such as social enterprises tend to have very rudimentary IT, and trying to find parallels when who's going to pay for their IT systems, who's going to pay for all of this so it's compatible, is a real challenge that's just holding everybody back at the moment. Again, residential and domiciliary care providers, which tend to be private organizations, will tend to have limited IT, and it might mean that the people who are out and about won't have as much IT within their care planning system. And of course, when we've got areas where we've got really important information such as safeguarding, communication between services and schools is something that can't really happen outside of time. And so again, the systems are holding us back, and the silos are making it very difficult for us to be able to engage with them. Finally, for those who do implement IT infrastructure and new kinds of things, whether that's an electronic patient record or, trying to move away from fax, we've got, the PIFU. It sounds like a Scandinavian yogurt, but it's actually the patient-initiated follow-up mechanism for secondary care. And we've got a lot of these drivers and things that we're trying to do. But again, the problem is we have these systems, but we always fall down at the last hurdle or the last mile, in that to be able to make sure that something securely gets to the individual, it needs to be secure, it needs to be accessible, and we're not necessarily achieving that at the moment. I hope these resonate with you. And I would say that from the work that I've done nationally with other different parts of the NHS, it feels like we're going to have to find a way to tackle these in whatever way in order to unlock transformation to be able to improve care around communications. I would like to now jump into some work that I have been doing with the support of a whole number of individuals who are not getting any credit today in Zivver in terms of interviews and case studies and talking to a whole number of different organizations. And I'd like to take you to the Netherlands, which I'm sure is looking absolutely beautiful at this time of year. And unfortunately, we're all sat on our desks not enjoying a lovely tulip field. But if one can imagine, then this is where we are today. To give you a bit of context on care in the Netherlands, the Netherlands is similar in terms of prevalence of diseases, in terms of the population. It's a developed nation just over the pond. But as a system, it's an insurance-based system with a mix of statutory and complementary insurance. So more similar, I suppose, to Germany and the US than us in the National Health Service. We tend to be quite unique in that sense. However, population of 18 million, 18.9% are over 65. So they have a higher prevalence of over 65s than us, which is at 18.2 in the UK. They have a mix of regional private hospitals. And for many, they have what we would call vertically integrated. So many of them having community roles. However, the Netherlands is also home to Bertolk, who is one of Zivver's clients. It's really interesting getting into what they've been doing. But they are one of the organizations which spans across the Netherlands and is known as a world leader in terms of integrated community care and driving really interesting patient outcomes. I think one thing which is really pertinent to this is that when we look at the Netherlands, we're looking at a system who is more proactive or has been more proactive in terms of driving their integration. So their integration has happened in two regulatory hops, which has been the first one in 2008, which set the scene for it, and 2015, when they brought through significant integration based on LERT's 5 laws of integration, which started in the UK, but has now been really sort of brought into their system. And so as integration goes, they are 8 years down the road rather than us in the UK, where, we are still, not the UK, sorry, in England, obviously other parts of the UK are more integrated. But in terms of England, where, we are still kind of going through that cloud of reform and it's still not clear what our system looks like as an integrated system. Off the back of being ahead of the game, one of the most important things that I think factors into all of the things that we're going to be cover in terms of technology here is that there has been a big regulatory shift to make sure that any communications that happen with citizens, whether that be through the judicial system and a number of different areas, has to happen with secure electronic communication and digital interactions across these services. Now, this is driven both by the Netherlands and by EU law that's coming in. I mean, this is really interesting because we haven't seen this in the UK, and there's been a real drive to move away from paper-based, which we haven't necessarily had as much by mandate in the UK. And so there's really been some lessons for me in terms of what they've been doing in terms of this. The mission for the remainder of this is to take you through some of the things that we've learned in these interviews from the work that I've been doing over the course of 2023. Try and understand some of the lessons from these systems who are slightly ahead, and then to try and translate that into the challenges for the NHS. So the first thing around these systems is that, as Obi said, we have a huge coverage of organizations using Zivver in the Netherlands. And I'd like to just pass back over to Obi to talk about the one use case where 100% of the organizations using Zivver are using, because it's the primary use case of Zivver that many first got it for. So over to you, Obi.
So I think at this stage, and to set the scene, it would be really important just to let you know who Zivver are and what we do. First of all, we augment your existing technology stacks. We integrate into your existing workflows. So think about Office 365, think about Gmail, think about NHS Mail. If you strip it back out from kind of the integration piece and how we augment workflows, what is it that we're actually doing and how do we approach it? Well, Zivver is focused on securing communication digitally with a core use case of email. And the value proposition really focuses on 3 key areas: before sending, during sending, and after sending. If you think about before sending and clinician to patient care and all of the kind of problem statements that we've addressed today, the fundamental challenge is that we do not employ clinicians to be information security professionals. We employ them to do a job to be able to provide fantastic care to our communities and to the patients that they serve. And so therefore, we need to equip and empower those individuals with best practices that are underpinned by technology. And so really what we're doing in the first instance across the before sending piece is building a relationship between the sender and the recipient to ensure that we're making the sender aware of the types of information that's being shared. So for an example, if an NHS number is prevalent within the body, the subject line, or an attachment, Zivver will let the user know, and in this case, the clinician, that there is sensitive information such as an NHS number that is about to be shared with X recipient. By doing this, we can start to apply right-size security underpinned by best practices in a very automated way, taking the responsibility out of the clinician's hands. That is fundamentally the before sending piece. The next piece is really around during sending. If we build a relationship between the sender and the recipient and we applied the right size security based on context, we want to ensure that security level is best in class. So Zivver leverages zero access architecture encryption, which essentially enhances Microsoft and transport layer to provide zero access. So we are never vulnerable to insider threat. It's why we've seen such adoption across the central government, local government, as well as the NHS and healthcare systems. If we build up a relationship between the sender and the recipient, we've provided awareness to the clinicians, we've locked down that content with right size security and encryption. We then want to make sure that only the intended recipient has access to that information. And this is where the last step of after sending really comes into play. We leverage multi-factor authentication to be able to ensure that there is a frictionless adoption or access to that information, but equally ensuring that only that intended recipient has access. And by doing this, we're able to provide insights, reporting, and access control that enables, one, the business to understand where information has gone, but equally, if a mistake has occurred, to be able to revoke access to that in real time, and equally enable and maximize adoption on the recipient end to be able to access that information and respond in a timely fashion. So that's it in a nutshell. Would love to take you through that in a little bit more detail and deep dive into some of the applicable use cases that we see across the NHS and also other healthcare systems. But at this stage, I'm going to hand back to Liam to take you through the rest of this session, and we'll field any Q&A at the back end of today's webinar. Thank you very much.
Thank you. And so it was quite like, whilst this session is very much around trying to look at best practice, obviously it's very difficult for me to proceed into the next bits around what was used and how without knowing the key use case. I think also when we were interviewing people, we haven't really necessarily profiled this, but the problem statement one of data security and data breaches, this was that 100% went with Zivver for this exact reason, because they wanted to stop bad things happening. They wanted to be there in real time and have you sort of depot on the shoulder as people were sending emails. That's not my words, not theirs. And then obviously when things did happen, they had the ability to kind of have some way of dealing with that when it happened. So that was the primary one, particularly around the fact that in the Netherlands, there was legal compliance that had to happen around that, which is why I think one of the reasons why Zivver sort of has grown to such coverage within that system. So I'd like to now go into some of the other ways that they've started using it. So everything that comes after this moment is very much, we bought Zivver for these things, but actually these are some of the things that we've been using it. Because now I'm not going to go into lots of details. If there's any of the areas that I cover that you want to know more about, just speak to OB and the team and they can kind of go through some of the specific things, because this is very much around case studies and lessons that we can apply in the health service. But very much it was, we bought it for this, but actually we use this other feature that is sort of in the Lego toolkit that Zivver has to be able to kind of improve our workflows and to transform how we work. So the first one, which is probably a sort of hopefully a no-brainer, but something which is incredibly difficult, is around their last mile. So what I think it's just about 18% of the Dutch hospitals using Zivver hooked it into their EPR. Now, the majority of those were Epic, and there's quite big coverage, and I think that's probably in relation to the figures that was being used, where they could use that in the last mile to their patients. Now, what this effectively would be is within the patient record system, if, for example, they wanted to do a discharge summary, an appointment letter, the kind of things that people have been deploying portals for, instead of sending physical letters and portals, which is physical letters is about to become illegal on the 1st of July in the Netherlands anyway. What this meant was that they were able to send structured communications initiated from the system to the individual without having to add any extra further administrative burden. As we know, care logistics take up quite a lot of administrative burden. The next one And I think this is a really interesting lesson actually for the NHS app. And I really hope that the national team in England will be engaging to get some lessons from other health systems around driving portals, such in the Netherlands. Because what we found is that a number of hospitals and primary care organizations, for example, when they had longer term patients, they were managing to kind of train them to use the app and get them to use it. But obviously in care, we have frequent patients and we have infrequent patients. And for those groups where it was relatively infrequent and less planned interactions or less support in terms of long term, what they found is they were really struggling to get people to be able to use the portal of choice. And so what they started to do was, as actually the King's Fund recently recommended, if you haven't seen their document around digital inclusion, is around having multi-channel communication. What they found was actually they needed to kind of bring this in for those where there was more infrequent interaction. So it was more accessibility and there was less of a installation and training barrier for them. And so now many of the organizations are using the two side by side based on the perceived needs of the service user. Next up was around capturing information. And I think this is one of these where in the research, a lot of it was relatively early stage in anticipation of what's called the WEGIDS law that's coming through, which is effectively where, as I said, it can't be paper-based. So what they were starting to do is where they would have been sending questionnaires before and getting people to post it back in, they were now looking for an alternative that their clinicians could use. And for a number of clinicians, many of which in outpatient services, they were trying to look at where they could, one, optimize the patient journey. So for example, someone has to come in, then they have to sit down, they have to fill something in. It takes longer, particularly for those who are doing regular interactions with the system, and also the consultation experience. Like sometimes there's questions where people might want a little bit of time to be able to fill it in. They felt that they could use this to be able to send it digitally and be able to receive it back. Obviously, in terms of clinician workflow, if the person is filling it in and you've got to then read it and then you've got to do the consultation, that reduced the ability to have flexibility in how they did it. So, for example, they had a number of patients. It allowed them to be able to use Zivver to send that through digitally, to receive it back, and then be able to use it. Now, of course, they could always use it in person if it wasn't filled in, but it was a way that they've been looking to improve workflow. And finally, which is probably the biggest use case, is around the admin burden around typing up the patient notes. So everybody who has to fill something in paper, there is the same amount of time of someone in an administrative role having to type it up in a system, or even a clinician in some cases as well. So we started to see a fair few use cases where they've been using this to see how they can transform their service. The next one, and I think this is really important as we start to think and talk about exclusion and inclusion, is that there was a number who actually started using the flexibility of some of Zivver's tools. So when emails go through from Zivver, there's the ability to customize what gets sent through and how, and to be able to provide like buttons and links for it to be able to go through. So there's one organization called Sierra and Lau, who is one of the bigger, if not biggest, providers of both health and social care for people with additional physical and learning disabilities. And they're a really interesting organization because they are health and social care. And what they did is they included within this a help me button. So it could direct the individual through to a video that they had done themselves, so they had control over it, but then also to be able to use that to have a call us if you need help. So it could go through the central help desk in order to be able to receive this information. One thing that was really interesting, I'd love to continue to dig down into this, is actually many of those with learning disabilities, their preference. So Zivver has the ability to choose which validation types. You've got like an email, you can do it as a code that you put in, such as someone's NHS number, or Dutch equivalent, or you can use like mobile phone, where like on many of the services we use, it sends a text and you can put it in. And one of the interesting things was that they were using it. And so the hypothesis, which I'm really keen to explore a bit further, is that many of these organizations would probably be already training and working with these individuals to use other digital services like online shopping. And so actually, given most of them use text validation, it was probably that actually they were already kind of working as part of that. And it was a more familiar thing versus some of the others. So actually, when we talk about two-factor authentication for people with additional needs, that there can be more to the story in this, rather than some of the lower levels of validation that we might have perceived initially would have taken place. Next up is around sensitive information exchange across provider types and academic institutions. And from a system level, obviously a system that's been integrating for the last 8 years, unsurprisingly, they've had the same challenges around how they can get different kinds of providers. The difference in the Dutch health system is that they have lots of providers who are private, and so obviously need to be working together in different ways than a system where we can have more directive. And I think in the 2015 law that they brought through, it was much more around requirement to comply with integration agenda across different private institutes. But I haven't covered all of them, but we ended up pulling out a number of different ways that people were using it. Now, just to give you a bit of information around why this became the case, is that Zivver allows you to send any media attachment, files, folders, up to, I think it's 4 terabytes of data, so more data than I've ever produced in my life probably, and that you can basically send that from one to the other via a secure channel. And so there's a number of use cases that we came up. So, for example, referrals across providers securely, rather than doing it in a more insecure email. They were using this from general practice to hospitals or back when obviously someone was discharged. CT and MRI scans was an interesting one because previously they were having to use DVDs and post them to people, or use a very, very specific and quite clunky system to be able to send this. So the rapidity and the speed of this and being able to do it easily and save time was quite a big one. This is one of the biggest use cases that came through. Next up, in terms of care transformation, one of the interesting was around, for example, specialists or GPs that are working in the areas, in the community providers, for example, the social care providers being able to send a media file of photos or potentially even videos of wounds or bed sores and stuff like that. Finally, and it's a really interesting one, particularly as in the UK, we see organisations start to kind of get more involved in research work as part of the legislative mandate in the UK, is that for areas where they had DNA sequencing, so DNA, I think, has 4 billion data points, which they send through, often in different files with lots of supporting stuff. That's not a file that you'd generally be able to confidently use and send using most email providers. Whereas because of the file size and the ability to add folders, this was where they were using it as a primary use case to get towards academic institutions and partnerships to be able to send lots of different files across them, particularly between, for example, teaching hospitals and their partner universities. There are a number of other ones that we're going to start case studying over the coming months, but at this particular time, these were sort of the 4 different kinds that came out that illustrated how they were using it in different ways. One of the benefits, can't press right on this, one of the benefits that the regional hospital Queen Beatrix mentioned was just how how quick and easy it was for them to be able to do it. And they found that when they were buying the initial thing, it was quite a surprise. They were just like, oh, right, we can do this too. And this led to a lot of transformation they've been doing in terms of sending health records in a secure way when IT systems aren't able to facilitate that. The next one, and I think the final one of the case studies that we came through, was actually around supporting the patient to initiate secure communication. I felt this was really relevant in relation to the National Health Service as well, because as I mentioned before, we have initiatives such as PIFU, patient-initiated follow-up, and other ones where we're trying to help people to be able to self-diagnose rather than requiring the system to kind of play the middleman. And particularly for services where, rather than just giving everyone an appointment to follow up, so if you have the need to be able to do it. Now, because of the legislation coming through, it limited the ways that people could send this in, such as letters and faxes. And as a result of this and the legislation that is coming through, one of Zivver's tools, which has really kind of stepped up, is what's called the conversation starter. So that means that you can start a secure conversation from the website, click in, be able to send a secure message, and then be able to pick which team that you want to go to. What was interesting is that on the website, because with Conversation Starter, you can set a different instance for different teams. Let's say, for example, the physiotherapy department would have on their physiotherapy page an instant portal where people could send you wouldn't send mood diaries to a physio, but I'm crossing conditions here, but like you could send different kinds of information to those. So it could be, for example, you're getting in touch and you want to send a video and say, this is my movement, I don't think I'm doing it correctly, could you have a look at it? And the physio at the other end could go, okay, I've just seen it. You might want to do X, Y, and Z, or I might want to see you because I'm slightly concerned about something I saw. So being able to have that was a way that they could make sure that services could provide more flexibility. I will say that this is one of the areas in the Dutch system where they've mandated that services have to be able to have a way for patients to initiate into the system. So this wasn't necessarily by choice, but it was really interesting what came out of this as a result of this requirement sort of playing out within the Dutch system. So just to wrap up this part 2 here, from the 5 problem statements that I outlined sort of about 15, 20 minutes ago, the same challenges have been present and that they've been dealing with in different ways within their health system. And, many of the things that they either proactively tried to improve or solved, of course, relating to the first use case in problem statement 1, but particularly in 2 to 5, that actually the different kinds of tools, they found some really interesting and creative ways. And so I think the next phase of our work that we're very much looking to consider is, well, actually, how and where can this translate into the NHS? As Obi mentioned, there's a number of organizations that have started using Zivver in the UK, from ambulance services to vertically integrated providers, community providers to big hospitals. And so we're really now starting to look at this art of the possible and consider where it could be applied. I would now like to just spend a couple of minutes just wrapping this up by thinking about, well, where could some of these lessons and case studies be applied? Now, obviously, the difference in the NHS is that there isn't legislation which is really pushing this agenda yet. But there could be. We could start to see this next year, like Wes Streeting is doing the rounds at the moment, thinking about where we can drive digital transformation at a much quicker rate. And I think given this is happening in the EU, we can expect within the next couple of years, we might start to see these requirements come along. Translating these into clinical system service reform, I've identified 3 areas where we've been talking again to folks in the NHS about which particular services and areas they feel that they could use this. And I've provided all of these as question marks. These are hypotheses that we're really hoping that we can start to work with the organizations already using Zivver in England to try and see what can be achieved. So we can then, hopefully in 12 months, present some really good case studies from the UK that builds on the work in the Netherlands. So the first one is an area where we've got significant waiting lists and times, which is around hospital outpatient services. Inpatient service obviously is a bit more tricky because of the nature of inpatient services, but actually in terms of hospital outpatient services, what we've heard is that there's interest around, well, for like my child recently was getting his tonsils reviewed and there was a letter and there was no way to really be able to send something. So the ability to send regular information around tonsils to ENT departments. Similarly, we've had a lot of interest from the pediatric epilepsy department that, based on best guidance, is looking to try and see. There's a number of things that they are ideally based on the optimal model of support, because obviously symptomatic behavior happens at specific times. But also what's prescribed is exercises and specific tests from parents to see how this condition is improving or worsening over time and then respond to it. So the ability to potentially use that within that secure service by having a channel that goes with that individual patient from a shared box, for example, or an individual clinician's box, means that there is an ability to be able to send and receive information of different kinds. Dermatology triage is another way we'd like to see things, and people find it, the services are finding it very difficult to be able to reform. And then, of course, PIFU, just the ability to say, I'd like to send this information through and provide it, rather than having some form which is on the front end that they would like to fill out, which, if any of you have tried that, will know is difficult. Next up is primary and community services, which is probably one of the areas where, I really had to work to bring these down, because actually across community services, which some of you all know I know very well, there's a huge amount of different areas where there is potentially opportunity, because these are the individuals with long-term conditions where accessibility is really needed. So again, as per the problem statements, child stammering, capturing bed sores for nurses and, for example, care staff being able to send videos of bed sores to save that journey and that remote review happening. I once worked with a physiotherapy service, which I validated, where their ideal service model virtually was that if they did a consultation with someone, they could send through personalized videos so they didn't just have a leaflet, but then also be able to see things back so they can remotely review. The analogy that this physiotherapist gave me is, we can do it for a golf swing. Why can't we do it in health, right? This all exists in this area. Patients sending non-standard information to GPs. Yes, of course, we might need to receive blood tests in some way, but what about symptom diaries? What about things that we're collecting from apps that we might want to be able to send through as all of these other digital tools come through? Most of these digital tools can't get to the GP in an efficient way. And of course, one of the biggest sort of COVID areas that we saw was health visitors who want to be able to see things and to send things to parents within a short time frame, and be able to say, well, actually, this is an urgent thing, or this is not an urgent thing, or, this is how you can support your latching. Finally, and I think this is the one, of course, that talks to the integrating systems that we have, is we need to create these channels across lots of different other providers. So community assets, it's very difficult, as I described. A universal health services, being able to create a channel with a school to be able to send stuff to their send team. One example that I heard of in NDS or neurodisability services was around like capturing symptomatic behavior on a modern smartphone. Creates so much like file size in terms of a video, but actually quite often in terms of service model, someone will go in and they'll sit there and kind of spend a number of hours to help assess that person, if and hoping that they will be symptomatic so they can observe this. Of course, this offers a way where it can be caught at the time that symptoms are happening and be able to build up a better picture of how that person can be supported. And then, of course, being able to expand referrals. We're trying to find ways that people can intervene and prevent and be proactive in terms of care. And, being able to create these secure channels could make a real difference. So I'm just going to hand back over to OB now. And this is me done to talk about, I suppose, that some of the different Lego blocks that I've been alluding to in this, and then really keen to see what questions any of you have at the close of this session.
Fantastic. Thank you, Liam. Very thorough overview and incredibly powerful, which for me ties really into kind of the key initiatives, themes, and value drivers we're seeing across the Netherlands, the UK, but also across the entirety of the EU from the organizations that we work with. I think what's really interesting is that how much the required shift to secure electronic communications has sparked a new range, essentially, of applications across the Netherlands. That's only going to grow as the law comes into enforcement across the UK and other geographies in the next couple of months. And whilst we haven't seen, I guess, explicit drivers like this in the UK, we know that there is an internal caveat, which means the challenges are very, very similar. And we're hearing this from frontline staff and all of the kind of key personas I addressed earlier on in the presentation. But I think what we need to ensure is that people, from taking away from this, just from a Zivver perspective, is that the principle for Zivver is incredibly simple, right? It's being secure and being effortless in the way that you drive these kind of key use cases to address key value drivers associated to patient and clinician, or clinician to patient care. And at the same time, offering simple services and building blocks for care scenarios, as Liam is taking you through today. I'm more than happy to deep dive into these kind of 6 key areas or any other key questions that may have arose from today's session. We've actually had quite a significant turnout today, and as such, there's been a lot of questions that are bubbling up here. So I think one of the things that is in the chat is around mentioning different levels of validation or authentication. I think if we could bring that back to one of the specific use cases and ensuring that only the intended recipient has access to that information, but looking at what's important to NHS England and the directive all the way down into individual trusts and integrated care systems, in ensuring that digital inclusion and accessibility is the heart of everything we do around patient communication. And so therefore, we have to ensure that there's a level of flexibility to be able to access that information. And so Zivver provides around 5 or 6 different types of authentication methods to be able to access that information, providing flexibility based upon the organization or the care orchestrations, the use cases and policies from a communication layer. I hope that answers the question, but feel free to ask furthers and jump into that in a little bit more detail.
Yeah, let me just add to that, because obviously we've been talking about, we haven't really profiled the NHS stuff, but actually one of the things that we've seen with some of the NHS organizations using Zivver is for having a validation. They're using either the person's date of birth and their NHS number or some kind of thing that the person would be able to know. So basically when they get an email, if they put their NHS number in, they can then get access to this, which is a common way to do that. They don't necessarily have the same thing exactly in the same way in the Netherlands, but it's interesting that we've seen multiple organizations do this in the UK, which we'll be writing up soon as well.
Fantastic. Another question which is come through is, would other system partners need to buy it for themselves to be able to access it or be able to create a secure workflow? I think one of the things which is really, really important to maximize adoption across the integrated care systems, but equally for your patients, depending on specific use cases and what you're trying to achieve, is interoperability, right? So if we leverage authentication, and taking it back to the question I addressed a few moments ago, the way that they authenticate and recognize themselves is by that method of, okay, we are who we say we are, so we're going to leverage SMS for argument's sake, or we're going to use an NHS number to authenticate that we are who we say we are to access that specific content. And so what that really means is that, yes, other third parties within your ecosystem can purchase Zivver, but they're not required to. And I think that's really, really important, because for you as a care provider, need to ensure that you're providing a service which is easily adopted, with maximum usability, with the least amount of friction in terms of how your patients engage with your clinicians, how patients request information, how your clinicians engage with your patients to provide a 360-degree level of care. So in short, no, not everybody needs to purchase Zivver. The key trust or healthcare organization that is looking to provide this level of service, underpinned by key value-based use cases, would, but we drive interoperability across the care systems that you work with. There is another question here, and I think this one's probably best to be handled by Liam. The question is, what were the biggest challenges or blockers that organizations face in implementing these changes? And I think this is really coming from kind of the transformational layer, as opposed to how Zivver solves it. So Liam, we'd love for you to go through this.
Yeah, we did ask a number of questions about, I suppose, the transformation, how it changed. Like it differed, but I think that the point that really comes out to me, just thinking about what we covered, is it was very similar to the kind of challenges that we would see in any organizations, which is time, which is pressure, which is people, and that being implemented. I suppose one of the learning lessons around transformation where it was working well was that they took an education rather than a centralized approach. So in that, they were going to the teams and saying, well, they were training and educating around the building blocks of Zivver and saying, how could you use this for transformation, rather than trying to sort of centrally work out. Now, I think as any of us who've tried transformation across lots of different kinds of services will know, that all the services are different. And I think that probably speaks to the same challenge that we would see, that actually realistically utilizing these tools, and this is very heavily on my take from what we saw in the interviews, but actually around that people were, it was most successful not when they were trying to cookie cutter it across services, although of course in some areas commonality was the case. Like, there are some services where actually secure email is more challenging, and being able to engage with particular people, and they have to do it in a different way. If you've got highly complex, frail elderly falls patients, that's less of an area where it would be direct with a service user. So I hope that's answered the question. Like it kind of differed from case study to case study, and I'd like to get into that more with some of the UK organizations as we kind of take this forward, really.
Fantastic. Thank you, Liam. Very comprehensive. There's two more questions here that we've got. It said, you mentioned Epic. Did it integrate with any primary care systems? So I think the reality is, Zivver can integrate into multiple kind of source systems, electronic patient records, various other different elements. I think the question that for me that sits around that is, what is it that you're trying to achieve? What are those specific communication workflows? How do you look at the automation of integration, right? So when we talk about automation of integration, it's why do we want to put more labor on the individual trusts to actually be able to manage this secure workflow? How do we automate that in terms of information related to your patients to ensure that the communication level is incredibly seamless? When we start to think about authentication, when we look at NHS numbers, for argument's sake, or your date of birth, or potentially SMS validation, all of these need to be kind of centrally managed to a certain degree. It doesn't have to be centrally managed. You could also use it on a user by user basis. But when we think about economies of scale, if we think about reducing overhead through total cost of ownership and ensuring that you have an automated play to ensure that, one, your clinicians can focus on doing the job, frontline staff, and actually communicate effectively in the most secure way within a very, very stringent and pressurized environment. We need to take that burden and that labor away from those individuals. And so, yes, integrate, and two, we can automate to provide, again, value that's tied to existing workflows for your users.
Yeah, I'm glad you took that one first, actually, because I wanted to go into case study notes, because there was one other example that we had in that Zivver was integrating with a system called Medicom, which I think is kind of the equivalent to EMIS over in the system. It's the largest GP information system. And I think it's quite inceptive that we didn't necessarily have any of the, like, the sort of how it was being used, which was our focus, but it had integrated, and they were actually using that to have inbound messages using what's called a SOAP messaging format and using HL7 version 2 in order to actually get messages they receive to be put onto the system. That's on my list of things that we want to kind of really drill down into the case study, because I'd like to know how that's actually being used by the primary care services. But so there are a couple of examples, but that's an area that we're really keen to explore further and also explore with UK systems. So I know in West Suffolk, we've been doing a bit of stuff around integrating with, which system is it? OB, do you know? I think TPP and their secondary care system as well. So that's kind of starting to come through as well.
Fantastic. Thank you, Liam. I'm just very conscious of time. We're close to the top of the hour. I think we've got time to field one more question. The last question we have here is, Liam, you mentioned around sharing large files, images, ensuring you got bi-directional communication. How does this work? So one of the things that Zivver enables is large file transfer within your existing email workflows. Remember, I keep coming back to existing workflows throughout the entirety of the positioning here, because we do not want to disrupt what's usual behavior for your users or to have to drive another level of education. But if we take it back to the core question, you can use the Outlook or the Zivver attach, and we support up to 5 terabytes in large file transfer. We use the same mechanisms to do contextualized analysis. So let's take an Excel spreadsheet with a hidden tab with lots of NHS numbers in there that shouldn't go to specific recipients. Zivver will enable you to enable that large file attachment, but also we will scan in real time to say, by the way, Mr. User, in this attachment, there is NHS numbers. You should not be sharing this unless there is the right size security applied based on company policy, which can be automated again. The second piece there is, let's think about CT scans. Let's think about the videos, 4K enrichment when you're using it from your smartphone. Traditional methods of sharing information within Outlook, when it goes from 11 megabytes to 12 megabytes, your computer says no, or you have to go to www.dropbox or some other kind of file sharing element, which is incredibly insecure and creates shadow IT. Zivver augments all of this and builds it into your email workflow to ensure that you manage security and usability at the same time, underpinned by value-based use cases. So I hope that answers the question. You heard my alarm go off there very briefly. We're at the top of the section. There's my contact details there if there are any questions or queries as a follow-up. But thank you very much for attending today's session. I hope you've seen some benefit and it's been thought-provoking, and look forward to connecting you with in due course. Thank you all.
Thank you.